Hello, I'm Jane Bolland. I'm a GP nurse in South Australia, in Adelaide, and I've also had the privilege of serving on the board of APNA for the last 2 years. So welcome today, and now we've got Dr Chrys Michaelides, very good, and he's going to speak to us about CDM and osteoporosis, so take it away.
I'm a GP, I'm not an expert in osteoporosis, but I have expertise in chronic disease management. My philosophy is that it's person/patient-centred holistic management, and it is the growth industry of the healthcare system of Australia. As the population is ageing, we are seeing more and more people living with chronic disease. As a result, general practice is being overloaded with where it's going to share its time, because at the end of the day, general practice and nurses in general practice need to help manage patients with immunisations, the aged, diabetes, osteoporosis, coronary artery disease, heart disease, chronic kidney disease, osteoarthritis, and all the other stuff that general practice does. So there's competition for the GP's time in managing chronic disease. And so the only way that we can cope in primary care is to develop systems that will make our time better used so we get great outcomes, but at the same time not spend an inordinate amount of unbalanced time, because we still have to see all those patients with all those disorders. So this talk is based about what systems we developed when we're looking specifically at osteoporosis. Now, the normal disclaimers, the disclosures about what I've presented, and I think this is important when we look at the learning objectives. We want to increase our understanding and knowledge about osteoporosis. Why are we even in this room if osteoporosis is just, well, you know, brittle bones, it happens as we age? Does fracture carry a morbidity risk and burden? And why does that morbidity increase as we age? What happened in our practice that actually gives me the opportunity to be here and share that evolution that we went through? And where does a program that helps in automation and help with systems fit in at the end of it? This is the outline that I want to adopt. Why is osteoporosis important? Our experience. Then we're going to do a group activity, and then look at finding the at-risk and undiagnosed with osteoporosis. Another group activity, then look at what tools we're going to have available to us now and in the future, and then reframe. So, why is osteoporosis important? You know, it's a statistic, but everybody knows about diabetes. That was what started me on my journey in chronic disease. And I've heard Carl say, Chrys Michaelides, the diabetes guy. Yes, I've done a lot of work in diabetes, whether it's published data, looking at pathology, looking at A1C control across Australia. But osteoporosis, when I went to a few meetings and I had GPs say to me, Chrys, what are you doing here? This is on bones. And I said, well, I need to know about that. And the first meeting I went to was too hard. I thought, no, can't possibly do anything with osteoporosis. I'm too busy with diabetes. Went to the second meeting and Neil Herndon said, you're back. I said, yep. He says, it's not as hard as you think. It's actually easier than diabetes. And he convinced me. I went back, started to get involved in osteoporosis, and the journey started. And then you start to look at statistics like this. Didn't change the number. That's actually, it's not 2,105, by the way, it's 2015. But every time I looked at it, my brain converted it to 2015. But if you look at the statistics, poor bone health, which is osteoporosis and osteopenia, 4.74 million in Australia. And look at diabetes, 1.2. Obesity, 11.2. And percentage of people over the age of 65, 11.6. In 4 years, you know, that's not a long time. It's already May, the middle of 2018. In 4 years, we're going to be looking at 6.2 million people with osteoporosis or osteopenia. Why? Because the population is ageing, number one. But look at diabetes. There's more osteoporosis than there is diabetes, but diabetes gets a lot more attention because it's got a lot associated with it. But it's still less prevalent, yet general practice doesn't have a problem developing strategies and tools and mechanisms to manage patients with diabetes. Why? It affects the younger. Osteoporosis, everyone thinks it's an old person's disease, whereas younger patients are getting type 2 diabetes, and we're seeing more obesity, and it's projected that 78% of our population by 2022 to 2025 are actually going to be either overweight or obese. That means only 1 in 3 people will actually be a healthy weight. That is very scary because linked with that will be the increased metabolic disorders that we're going to see. Then what you've got is the lifestyle-related and reversibility. Yes, I can reverse type 2 diabetes if I exercise and lose the weight, or I can get into a metabolic remission, but I can't do the same for osteoporosis. Multi-system complications, eyes, heart, feet, kidneys. Well, the same doesn't happen for osteoporosis, therefore it doesn't get as much attention. Politically, Australian Diabetes Society is far more proactive than Osteoporosis Australia. You don't see any politician or celebrity standing up saying, I broke my hip, or I've got vertebral crush fractures. And the imagery of the disease with diabetes is far more horrific. An amputation versus a wheelchair or a walking aid. So the action point from this part is poor bone health is real. It is high prevalence, and what we need to do is find them. Now, these are the current statistics for osteoporosis or poor bone health in Australia. Overall, 14.3% of people aged 55 to 69 and 28% aged over 70, with obvious more female prevalence than male. Osteoporosis is an expensive disease like diabetes. It's very expensive. Fractures per day, 395 in 2012, projected to 500 in 2022. Fractures in 12 months. Now, fractures are the issue. It's the end organ damage. Fracture is to osteoporosis what amputation is to diabetes, what a myocardial infarct is to coronary artery disease, what a stroke is to cerebrovascular disease. It's an end organ damage. And the costs are phenomenal. So we really need to start remembering that diabetes, even though it's the poster boy for chronic disease and it gets all the attention, osteoporosis deserves a similar respect and attention. So if you look at it and think about end organ effects and loss of function, yep, diabetes has got a lot more. No argument. But doesn't that make osteoporosis much easier to manage if you only have to worry about one end organ damage, which is a fracture, versus having to worry about all the other systems that are affected by diabetes? That is why Neil said it's so much easier to manage osteoporosis than diabetes. There's less effort required. Because at the end of the day, prevent a fall, you prevent a fracture. Versus, I have to have well-controlled diabetes. It's not just about controlling glucose. I've got to control blood pressure, cholesterol, their weight, their smoking, their physical activity. So there's a lot more work required for type 2 diabetes than there is for osteoporosis. So osteoporosis is easier than diabetes to manage in primary care. So action point 2, osteoporosis is expensive both to the patient in quality of life and to our health budget in the cost. We have a responsibility to patients, right, to help maintain their quality of life, and to the community, because we all contribute, our taxes contribute to that health budget. Well, they're using our taxes for the health budget. So if we can reduce the cost of any chronic disease on the health budget, then our monies will go further. And we need to be proactive. If we're just reactive to the process, we're going to miss the boat. And if it's not primary care, meaning general practice and primary care nurses, who else is it going to be? Because it's certainly not going to be the specialist. As I give you some cases later where they send a patient back who's fractured her wrist, falling in the shower, and I've cured her, see you later. And no mention about hey, maybe at this age she's actually got osteoporosis because she's had a fragility fracture. So how do you prevent end organ damage in osteoporosis? We want to prevent the fracture. And the process we need to do is understand why a fracture happens, and there's a thing called the fracture cascade. Once you've had one fracture, it begets the risk for a second fracture and a third fracture. In my practice, I argue, why are we going to wait for that first fracture before we worry about osteoporosis? Shouldn't we try and prevent that first fracture? Because what if the first fracture is a hip fracture? It's okay if they break their wrist, but what if that first fracture happens to be a hip fracture which alters their quality of life forever? So you prevent a fall, prevent a fracture. The consequences of a fracture, now these are very striking statistics. As I said, a fracture begets a fracture. 40% of second fractures happen after a first fracture. 53% will see a deterioration in their quality of life and they'll need walking aids. 18% will enter long-term care and 25% die within 12 months. Now, it says women. Let me use the example of my father-in-law, aged 82. Fell over at home. I was in Sydney at a meeting. I'm on the plane. I get off the plane. I've got all these messages on my mobile. Dad's fallen over and we've called the ambulance. We've taken him to hospital. Get to hospital. He had a fractured hip. He had the hip repaired. He went into rehab for 3 months, right? Because he needed all that physio and rehabilitation. The home got changed. All the safety aids got put in place. 3 months to 4 months later, he had a second fall, hit his head, bilateral subdural hematomas, died 10 days later. All right, so now that happened, and at that point in time, I was not as proactive in osteoporosis as I became. That event prompted us, because I then went back to the surgery after his hip fracture and said, hey guys, osteoporosis is a devastating disease. It's silent, but what happens is that fracture actually discloses the osteoporosis, but it's too late because it's a fractured hip. And as a consequence, we put our systems in place after that. It did nothing to help my father-in-law, but it's helped a lot of other patients since. Why are falls important? 1 in 3 people over the age of 65 will fall in any 12-month period. Nearly half of all falls occur in the home and in the immediate home surroundings, as in the backyard. Falls can result in minor injuries, but as they get older and they fall, those injuries are no longer minor, they end up being major injuries. 90% of hip fractures happen because of a fall. Now, it used to be argued that they broke their hip then fell. That's what the orthopaedic surgeons used to say. We now know it's the other way around. They fall and then they break their hip. It's estimated that up to 6% of falls will result in a fracture. So that's a lot of falls and fractures. So prevent a fall, prevent a fracture. Now, under the age of 70, if you fall and you stumble, and I'm now 60 and I stumbled the other day as my foot got caught around my bag and I fell on my wrist. And it was the wrist that I had my carpal tunnel operation on at Christmas, and 3 months later I'm going, oh no, I'm actually going to aggravate and I'm going to get scarring. But I didn't break anything. So young people fall and they break their wrists. Older people are sarcopenic. They've got weak muscles. So they're walking along, they get tired and they fall backwards. And they end up impacting all that force on their hip and they break their hip. So depending on your age, there's a more prevalence of fragility fractures, meaning upper body in the younger versus hip fractures in the older. So if we're going to prevent falls, the best way to do it is with a structured multidisciplinary approach, looking at structured care, and the chronic disease model is the way to do it. Diabetes, as I said, is the poster boy for chronic disease. And when you look at a diabetes chart with the patient at the centre, and the number of people involved in their care, it makes this look, no, this is pretty ordinary, because diabetes will have more people involved. But this is not ordinary. You need an exercise physiologist to improve muscle strength, in particular limb girdle and proximal and hip flexor strength to help prevent a fall. Patients come in and say, why do I need to do this? And I go, stand up, and I push them, and they go, and they stumble back. And I said, okay, now think about it. I'm going to tell you I'm going to push you. And I push them, and they stop the fall. Now, if you haven't got strength in your hip flexors, you're not going to be able to prevent that fall. Hence, exercise physiology programs to improve strength in hip flexors helps prevent falls. They'll still stumble, but they won't fall. Podiatry, footwear, loose footwear, gait, they walk inappropriate or in an unbalanced way, increases the risk of falls. The problem is everyone wants their toenails cut, but they don't understand that podiatrists are not pedicurists. Right? It's a battle. My son is a podiatrist who works with me, and he says, I only need to see an osteoporosis patient once a year to check their footwear, check the wear on their shoes to see if they're putting themselves at risk. And I said, great. Patients go in, he examines them, gives them the advice, and they think, aren't you going to cut my nails? And it's very disillusioning, right, as we were discussing. But podiatrists is important for that. They've actually done studies where they've reduced falls risks. Medication reviews. Medications that increase the risk of a syncopal episode or postural hypotension are important to know about. So patients with Parkinson's disease who are also on antihypertensives, or patients on antidepressant therapy, anything that increases what we call the anticholinergic load will increase the risk of a fall. So home medication reviews are important. The optometrist, if patients lose their depth perception, they can't see where the next step is. And as patients age, they end up with tunnel vision. They lose their peripheral vision. The occupational therapist, what are the safety hazards and the falls risks at home? And then can we get patients into falls clinics? So that becomes the chronic disease model where everybody is reinforcing a message. I review this at 3 months and not 6 months because the first thing that anybody gives up is exercise. I feel fine, I can't measure the gain, right? But the gain, you'll know the gain when you go to fall and you don't fall. The exercise physiologist, the evidence behind EPs and osteoporosis. As women get older, they tend to fall more inside the home on a level surface and less outside. Most common causes were trips, slips and loss of balance. 27% suffered an injury, but those taking part in planned exercise, more resistance training and active for 7 hours or more per week had fewer falls. Now we tell diabetes patients 3 hours a week is just for health and the prevention of progress of chronic disease. 3 to 5 hours a week is for health, the prevention of progress of chronic disease and weight maintenance. 7 hours a week is for health, prevention of progress of chronic disease and weight loss. 7 hours a week. Nobody wants to do an hour a day. How many of you do an hour a day of physical activity? How many of you do 5 hours a week of physical activity? Do I hear 3? Okay, so we're all doing what the guidelines say, 3 hours a week of moderate physical activity. But the data says if we're going to help prevent falls, we need them to be doing an hour a day. So if you look at trips, lighting and walking paths, all right? So you've got this lady in loose-fitting slippers going down a dark lit stairwell with grandkids' toys all over the place, with wires, shoes and obstacles. Now, it's done for extreme purposes to show you all the possibilities, but this is where the OT fits in. General practice is doing less and less home visits. And whether or not we've got nurses who can go and do domiciliary visits is another issue. But the OT, that's what they're trained and skilled in, doing an OT visit to advise on what they found. What about the podiatrist? Okay, Published data, 36% reduction in fall rates. So if you add the podiatrist to the exercise physiologist and the OT, what do you think we're going to get? Reduction in falls. And if we get reduction in falls, we're going to get reduction in fractures. And the issue is that it's a multi-intervention process. These slides are going to be made available. Okay? Food, look at that. So, I've harped on about fracture, because that's the end organ damage of osteoporosis. But fracture begets morbidity, begets mortality. And here is the morbidity attributed to getting old. As you get older, things wind down. All right? There is going to be a chronic disease state. But as soon as you have a fracture, look at what happens to the morbidity. Your quality of life goes down, and then what happens even more, on the next slide I'll show you, is mortality. So 1 in 2 older women and 1 in 3 older men will suffer an osteoporotic fracture in their life. And fracture begets fracture, and the more fractures, the more morbidity. But what about mortality? Women, because they've got more prevalence of osteoporosis, are going to have, by statistics, more fractures. Men, it's less common, but they still get fractures. But look at poor old men. We die much more than women when we have a fracture. Now, why? This is an observation. I've yet to determine why we die more, but we have less fractures, but we die from them. Fractures cause death and change lives. So, prevent the fracture and prevent the cascade. Stop that first one, and if you can't stop the first one, but at least recognise the first one so you can stop the second one. Don't wait for 3 fractures before we actually do something about osteoporosis. Because in my opinion, you can treat osteoporosis and you can manage osteoporosis. You cannot treat osteoporosis just with exercise and vitamin D and calcium, because osteoporosis means you've got poor bone health to 2.5 standard deviations loss, which is putting you at increased fracture risk. Managing osteoporosis is about that holistic approach. Treating is easy. Anti-resorptive therapy to achieve at least a 50% reduction in fracture risk. Managing means improving the bone density plus preventing falls. Improving balance, improving muscle strength, checking feet and footwear, and home assessments. So action point 3, fractures cause morbidity and they change lives. Structured care will work at preventing fractures and falls. And what we need to do is identify those who are at risk of fracture and also those who have already had a fracture and at risk of secondary and ongoing fracture cascade. So, who works with a structured approach to osteoporosis in your practice? Face down. Anybody? Sort of do. What do you do?
Well, everyone, I only do care plans, and so everyone that has a care plan, there is an assessment. Have they had a fracture? Have they had a bone density? And so it's just the risk factor and then sending for bone density.
Okay, have they had a fracture? Have they had a bone density? Okay, so filtering and finding them.
Have they had a diagnosis and no treatment? That's the other.
Okay, diagnosis and no treatment. All right. So, how many GPs in your practice?
2 in that practice.
2. How many patients with diagnosed osteoporosis in that, for those 2 doctors? How many do you think you should have?
Well, you should have about 7% diabetes, so if your risk of osteoporosis is higher than that, it would be 10%.
Okay. Yes?
I did a little bit of when I'm doing health assessment. I look at, my doctor will let me look at their medication, do a bit of medication review, and I'll ask them, I make it a point for them to do bone density tests depending on their age.
Yep.
Bone density tests, and some of them I will do like physical examinations on them. Stand by the wall, raise your arms up, and say if your head is flat on your back,
Yep.
or you're bending over from your neck, and that means there is a disc problem. So I'm going to highlight that.
Disc or vertebral fracture.
Yeah.
Yeah.
Vertical, sorry. And then, I do all that. And most times, I worked in a very busy practice before, and I think I was doing up to like about 10 to 20% Prolia injections. So I know that there are a lot of people on that
Okay.
having those problems. Yeah.
All right, now I'm going to tell you that we all underdiagnose and underfind them. And so I'm going to take you through our journey to develop a structured program. So let's consider structure. Joe is 72 years old. He gets lots of sun exposure and exercise. He's struggling because of his low back pain. He's been treated with anti-resorptive therapy. He's confounded by prostate cancer, hypertension, TIA, sleep apnea. His falls prevention is in place with good footwear and EP falls classes. His falls risk is high. He's had falls and he's fractured L2. And what are the areas that make us stop and think? I've actually put it up in uppercase and bold, okay, so it stands out. It's important. So, think about this is a tool that we've developed which highlights for the patient immediately areas that need attention. Falls risks, actions needed. Confounders, actions are needed. His confounders are his TIA, hypertension. Is he at risk of postural hypotension? Things that we can say, okay, it's not urgent that we do anything about, but we'll keep an eye on. His functionality, his falls and fractures, because we already know that and he's already on anti-resorptive therapy. So I'll expand more on this later, but it's about thinking in a structured way. So our system. Now I'm going to share with you practical things that we did. We managed it. It's doable. It's not impossible. It's not pie in the sky stuff. It's really easy to do this stuff. Some of the myths that I had to overcome and that we all had to overcome as GPs, and in particular, let's call it primary care. Adult patients discharged from hospital following a fracture have been treated appropriately. Yeah, is that? Nah. Poor bone health is complicated to manage. Nah. Osteoporosis isn't really an issue until a fracture occurs. If I haven't got through to you, stop the first fracture, then I may as well go home now because I didn't say it properly. Prevent the first fracture and prevent the second and the third. Fractures only occur in people who have osteoporosis on bone density. No. Osteoporosis is rare in men. No. Only patients over 70 need a bone density. No. Now, my myths, secondary prevention is the best way to find and manage osteoporosis. I disagree with that statement. Yet, a lot of my colleagues would say, let's wait for the first fracture, then we'll worry about it. No. What if the first fracture is a hip fracture? And we advise and we look for people with at risk of type 2 diabetes. Why not osteoporosis? You have a patient who walks in who's obese. The first thing we all think of, they've got diabetes. And the number of times you pinprick them and they've got normal blood glucose levels and you go, can't even use that to motivate them to lose weight. A smoker comes in, must have coronary artery disease. High cholesterol, almost certainly he's got coronary artery disease. They've got high cholesterol, you do a CT coronary artery calcium score, bloody hell, their Agatston score is 0. Can't even use that to tell them that they've got to change their life and stop smoking. So looking for risk factors is simply to try and grade, because all risk factors are cumulative. The more risk factors for a condition that a person has, the more likely they're going to develop that condition. So our journey started. I went to the osteoporosis meetings. It took me 2 meetings to get it. There was too much competition for my time with diabetes, heart disease, hypertension, CKD, and the fact that my patient base was getting older. It takes a lot longer to see a person over the age of 80 because it takes them a lot longer to walk in from the waiting room into the room. It takes them a lot longer to walk from the chair to the scales and back. Everything is on slow-mo. So if you look at it, I had to ask myself, well, if it's such an important condition, how many patients with osteoporosis do we have? Because the statistics mean nothing. If you say, look, 40% of your female patients over the age of 70 have got osteoporosis, what if I've only got 10 patients because I'm seeing kids and I've only got 10 women over the age of 70, that means 4. Well, but if someone said, look, you've got 150 women over the age of 70 who are going to have osteoporosis, that absolute number is far more motivating to act. So don't talk to your doctors about percentages, talk to them about absolute numbers. So this is what we found. When I did the PenCat extraction, I found, we have got a lot of osteoporosis patients and we're not managing them properly. So what are we going to do about it? Let's upskill. So as a group of doctors, we organised small group learning. We did it in-house. We invited endocrinologists in, radiologists in, podiatrists, exercise physiologists, OTs and dietitians. And over 6 sessions, we basically upskilled and we implemented systems. And what we did after each one was we did a PenCat extraction to find patients. So by the time we finished our 6 sessions, we actually had a database of patients that we knew that we were going to act on when we got all the skilling done. We had our planning meeting, we agreed, we upskilled, and this is what we found. So step 1 was, okay, we know what the statistics are. Have we found all of our osteoporosis patients? And given that we were coding, ICPC coding osteoporosis, not osteopenia, in with the osteoporosis, and this is pure osteoporosis, we actually had more patients than the statistics said we should have. So I think the prevalence is actually higher than what the Geelong study showed. And our males, are sitting up high as well. So our total male low bone health was 32% over the age of 70, and almost 60% of women over the age of 70 had poor bone health, which is osteopenia or osteoporosis. All right, so we said, we don't have to do very much here. Now all we've got to do is make sure they're on treatment. Step 2 was, well, what about the ones that are turning 70 so we don't miss them? So let's put systems in place for getting that bone density done for the 70 pluses. So our nurse printed up the list, looked at everyone who was turning 70, put a recall in place for the bone density. Whoops. And we then added a bone density to our health assessment to remind us not to lose track of it. The doctor acted on the recall and the cost to the patient was absolutely nothing because it's a Medicare rebatable bone density. What we achieved with the over 70s, this process started in 2014. So by 2016, what we achieved was that we were pretty well on target. We definitely were way above what we needed. So we were satisfied we were picking up all the over 70s. The problem is PenCat lumps together osteoporosis and osteopenia into one category. Whereas when you use ICPC coding and we use our software is ZMed, it gives you a report you're able to find by ICPC coding. So I don't know what software you use, but whichever one you use, be aware that you're going to over-report using PenCat, but that's okay because it's lumping osteopenia and osteoporosis together. It's still identifying poor bone health. But when it comes to treatment, you need to then drill down further who isn't on any treatment with osteoporosis versus who is, and what about the osteopenia? Are they actually an osteoporosis because they've had a fragility fracture and we don't know about it? This is where we had trouble, finding the 50 to 70s. What about this young age group? This was way more interesting. We were really underfinding when you look at what we're supposed to have. And we thought, what are we going to do about this? We've got real deficits in the diagnosis, so we thought, you know what? We'll actually mail them a letter. We will mail out our 50 to 70-year-old, 50 to 69-year-old males and females, and we will invite them to this new innovative technique that we've got, that we're going to do a risk factor analysis and send them for a bone density. I negotiated with the radiologist that they would do it for $60. One of my colleagues got it down to $50, which is practically nothing, which is what? How much is a pack of cigarettes these days? This will show the smokers. No. It's less than a pack of cigarettes or less than 2 packs of cigarettes. So it's, or put it in cups of coffee, less than 10 cups of coffee. So it's not expensive as a diagnostic tool to look for osteopenia or osteoporosis. We invited them. They would come and see the nurse. We would do the risk factor analysis. They then see the GP. I'd order the bone density, whether it was rebatable or not rebatable, depending on the risk factors. They would then go and have the bone density, come back, and we would have a talk. And the number of osteopenia patients that we found doing this was fascinating. But what happened? Women came. Okay? Thank God for the women. They came. Women are very proactive at preventative health. Men aren't. And the team interventions for women, fantastic. They took up to it, the exercise, and I'm fairly confident that we've done a lot of good with our female population. Men didn't come. Right? We stopped mailing them and made a decision, what a waste of time sending them a letter. We'll wait for them to come in, because they have to come in eventually, whether it be for their prescriptions or for their flu injection. And the response was, I feel fine. Why are you looking for something that's not affecting me and it's not causing me any discomfort? We needed to educate them better. So when we got that response, we educated about osteoporosis being a silent disease. And it's very similar to diabetes. You will not get a dry mouth or thirst until your blood glucose level is over 12. But by then it's too late, because it's such a silent disease. By the time diabetes is diagnosed, there's already coronary artery disease and cardiovascular disease and cerebrovascular disease. So what we achieved, this is what we had, this is what we expected, and in the men we had deficits. But we managed to almost find all the females with osteopenia or osteoporosis. It wasn't good, but it was improved. So what systems have we put in place to diagnose? We've selected certain clinical criteria and risk factors to look for, and we try to do timely searches to bring up reminders in patients' records. The nurse would upskill patients. So in my room, where the patient sits, there's this big poster about the risk factors for osteoporosis. Opposite where the patient sits in the nurse's room, there's a big poster again about stop the next break, stop the first break, because the next break you have could be your first break, and the next break you have could be your second. And it raises awareness. And to manage, we use the non-drug approach, which is the team care and the management plan, and the drugs are guided by the clinical condition. So managing osteoporosis in our practice, well, the management plan is easy to do. What's the goal? Falls prevention, fracture prevention and prevention of loss of function, and preserve bone health as long as possible. What are the actions? The patient and the GP have well-defined goals. The team care arrangement is everybody. The more people involved, the more likely we're going to have success. If we do a management plan and team care arrangement, the minimum is that, and a lot of practitioners will do the minimum. I just need me, another doctor, and one other allied health professional. And invariably, they all get referred to podiatry because it's easy. They'll put the pharmacist in for a home medication review. Thank you. I'm now going to get my 7 2-3 build and everything's fine. It's the most useless team care arrangement that you could possibly do because there's no outcome that can be measured. But when you do a good team care arrangement and you spend that extra time doing it properly and you're all here, which means you do it properly, right, you get great outcomes. And what the outcome that we're after is reduction in fractures. So let's look at a comparison between our diabetes control radar and our osteoporosis control radar, because you can have diabetes and osteoporosis coexisting. So in this instance, the action points are very visible to patients, and I use this all the time as a discussion point. And the patient says, why is it in the red? Well, that's because your A1C is over 8%, you're not doing more than 3 hours of physical activity, and you haven't had your eyes reviewed in the last 12 months, and you haven't attended the team care arrangements that we put in place. Why is this in the red? Because you didn't go to the exercise physiologist. Why is my falls risk in the red? Because you fell over last week. You know? And why have you put my activities of daily living functionality in the red? Because you're struggling to actually get your arms up and pull things out of the cupboard. You're struggling to do your laundry and your ironing. So visual tools that engage the patient to have a discussion about how they can become more involved in their care. So patients clearly see what actions are needed and it engages them to be involved, because it's got to be a person/patient-centred approach. Now, I've gone person/patient, but as soon as they've got a chronic disease, they're a patient. Yes, they're a person, but when they're in our system, we need to be mindful that they are a patient with chronic disease. Now, what about the costs? The nurse? Nil. Exercise physiologist in our practice, $15 out of pocket or nil. Podiatry, same, nil or 15. Dietitian, nil or 15. Optometrist, nil. Pharmacy, nil. It's a minimal expense to the patient to actually get Rolls-Royce treatment and engage with all the team members to help them prevent falls and fractures. So a well-coordinated, multifaceted approach. And you often hear this. The penny drops, the light bulb goes on, and they go, if this many people are involved, it must be important. It's not costing me a lot, but it must be important. And so you get engagement. So what we learned, there will always be non-acceptance. Males are resistant, they're immortal, they're Superman, they're bulletproof, nothing will ever happen to them, and they're ostriches with heads in sand. Women, as always, are quite willing to participate in anything that will keep them healthy and they're very proactive in preventative health. And we have to stay on top of it. We did all this work to create the system, and we were really great. You know, we kept doing it for a few years, and I've noticed recently that our eye's off it, and we're starting to fail. Why? Because other things compete with your time. So it's about developing systems. Somebody needs to be the coordinator in the practice that says, no, my responsibility is to keep the eye on the ball. Now, there's a study called the Translate trial in diabetes, which proved in a multi-centre study in the United States where they were able to show, and Translate stands for a certain letter. It's a team-based approach with a register, with administration, nurse-led, and it went on and on. But the key was that they actually had a site resource person. All right? They had somebody who took responsibility for coordinating the care. So for that diabetes. And what they showed was more feet got examined, more eyes got examined, more exercise got done, and it had a modest effect on the A1C. But they weren't interested in the biochemical changes. They were interested in everything else that got missed. You could do exactly the same for osteoporosis by simply having someone who's going to stand up and say, I'm going to be the coordinator of this. So in our practice, I'm the diabetes and osteoporosis and chronic kidney disease coordinator. one of the lady doctors, female GPs, is the coordinator of women's health. Another one's the coordinator of immunisations, because someone has to be on top of it. Whereas if general practitioners try to be everything to all the disease states, you're only going to do a little bit of everything rather than a lot of one thing. So it's spreading the load. So what could we do better? The fracture rates. Now, I've argued that the missed first fracture and under treatment for years, I think it's overstated. And I've got no evidence to support that statement. But I say it because I'm guilty of not doing this. But I've started doing it now. And one of the processes that we've put in place is what's on the bottom. Have we actually missed recording the fracture? The easiest way is to find all the patients who are diagnosed with osteopenia, all right? Because if they're osteoporosis, the likelihood is that it's part of our management plan, so fracture's been asked. But if they've got osteopenia and they're not on any anti-resorptive therapy, actually asking them, have you ever had a fracture? Because if they've had a fracture, and even though their bone density is not osteoporotic, but it's osteopenic, then that person has actually got osteoporosis if that fracture was a fragility fracture, and they need to be treated to prevent the second fracture. So the solution is ask the person that's in the room with us. Is it we don't record it as an event even though we record retinopathy, nephropathy, acute myocardial infarcts for patients with diabetes, but do we not, why don't we record fractures? Because we forget to ask, it's not in our face. And the diabetes has really trained us well to look for the end organ damages. So our structured approach, this is our assessment of our patients with osteoporosis, right? Now, I modelled it off my diabetes approach. My diabetes approach is A, B, C, D, E, F. A1C activity allied health professionals, blood pressure, body mass index. C is cigarettes, confounders and comorbidities. D is diet, doctor visits and drugs. E is exercise and eyes and erectile dysfunction. F is feet. And S is self-care and self-monitoring of blood glucose and symptoms. So I thought if I've done that for diabetes, why don't I do the same for osteoporosis? So activities of daily living, allied health professionals activity, blood pressure sitting and standing, bone density, calcium, confounders and complications, drugs or medications for OP, vitamin D replacement, vitamin D levels, doctor visits, dental review, dental extractions, distress re-osteoporosis, eyes, exercise resistance and balance, EP review, feet, falls and fractures. So it gives you a list. It's just like a checklist. Every time you do an osteoporosis consultation, you've got a checklist to compare against. So the business outcome is that osteoporosis is never on its own. It's either being present for 6 months or it will be present for 6 months. It's a chronic disease. And so it qualifies for a chronic disease management strategy. And as you do this, you find polypharmacy because, as I said, osteoporosis is unlikely to exist in isolation. And it's good medicine that needs to be rewarded. So from the business model for general practice, the minimum that should be generated for the practice is $700 odd per annum for a patient of the practice with osteoporosis. Now, if you've got a minimum 100 patients with osteoporosis, which is what we all have, that's $70,000 a year. That will pay for an extra nurse to help find all the undiagnosed osteoporosis patients. So the concept of using this is to use it as a funding model to create more work, to find more patients, so that the drain on the general practice, and you know, the bosses of the practice being the people that write out the wages bills and pay the rent, meaning the doctors, or in corporate health, the managers, they need this to justify themselves employing extra nurses. How many of you are solo nurses in general practice? Could you do with extra hands? Always. How many of you in have got one other person working with you? Could you do with an extra nurse? Yeah. So you're doing them all the time, and do you think you could do with an extra nurse to help you find all the yeah. So this is a funding model that if it's done properly and you get enough funding in, it should fund another nurse. The problem is that the practitioner looks at it and goes, great, that's mine. And they take it, and it doesn't get put back into the practice the way it should. So action point 4, look and you will find. Be systematic, use a structured approach, and it will pay for itself. So let's look at the case. So Elise is a hypothetical patient. She's got hypertension, she's on an ARB, hyperlipidemia, type 2 diabetes, she's got atrial fibrillation, and she's on an anticoagulant, and she's on an antidepressant. Okay. She fell over inside the home when playing with her grandchildren. She was taken to the emergency department by her daughter. She had a CAT scan, and it said because of the Xarelto that they were worried about, let's make sure you haven't got any internal bleeding. So she had a brain scan and a chest scan. She had pain on her deep inhalation. Well, maybe it's a rib fracture, maybe it isn't. Does she have osteoporosis? Yes? No? Possibly. Yeah. All right. If risk factors are cumulative, how many risk factors does she have for fractures and falls? Yeah. Hypertension, atrial fibrillation, type 2 diabetes, and depression. Why is type 2 diabetes a risk factor? Neuropathy, yeah. Neuropathy, vision, and there's a link between osteoporosis and diabetes. Their bone densities fall off, not because of drugs, simply because of the diabetes. And depression, the sertraline is an anticholinergic load. Link it with the hypertension, and she's on a diuretic component. All right? So postural hypotension is the risk. So she's got risk factors for a fall. Does she have risk factors for osteoporosis? Well, she's almost 70, so we know that she's sitting somewhere between 25 and 42% probability that she's got poor bone health. We also know that SSRIs do decrease bone density, and we also know that diabetes decreases bone density. So she is at risk of osteoporosis. How do you find these sorts of patients? Given I've just said we've got to find the undiagnosed ones, suddenly you now have got risk factors to look for that you can find by doing reports. Patients who have got diabetes, patients who are on anticoagulants, patients who have got atrial fibrillation. These are patients at risk. And we're doing a study at the moment looking at whether or not SSRIs can be used as a risk factor for detection of early osteoporosis. Right, what happened to her, right? Well, she was sent home in the hypothetical case, and nobody did any of this. They didn't look at her confounders, and they didn't look at the fact that she needed treatment. Why did she fall? She's already fallen, and we know falls and fractures happen. And her confounder with her hypertension and atrial fibrillation, she went on and broke her hip, and that disclosed her osteoporosis, and she ended up in an aged care facility 3 years later. Versus if the rib fracture had been deemed a fragility fracture because she was down on the ground with her grandkids, stood up, fell down, so it's a fall from a standing position. She suffered a fracture, which if she were 20 years younger, she wouldn't have fractured because she wouldn't have expected to break a rib falling over. Started treatment, which would reduce her future fracture risk by 50%, went to the exercise physiologist, had her hip flexor strength improved, so when she went to stumble, she could stop herself falling, she wouldn't have fallen over, broken her hip, and wouldn't have ended up in an aged care facility. All because the rib fracture did not alarm bell and say, this has to be a fragility fracture. You know, Joe, okay, he's 69 years of age, and he says, I'm getting shorter. This is the case that you said earlier. You know, his vertebral fractures have been undiagnosed and he's getting shorter. And that's really what this comes down to. You know, what 3 questions would you ask Joe or the GP should ask Joe that will help determine, he's 69, he's not 70 yet. If I say, I'll wait 6 months till he's 70 and then I'll send him for a rebated bone density. Does he live alone? Because if he falls, no one's going to find him. Does he smoke? What's his alcohol consumption like? What other medications does he take? Has he had falls? What are the confounders? Because I haven't given you information other than, I think I'm getting shorter. Pain. Vertebral fractures are silent. Most vertebral fractures are incidental findings, but the acute ones can be associated with pain and loss of function. What can't he do anymore? And as he says, you know, my grandson's towering over me, but also I can't reach up to the top cupboard because I'm now 3 centimetres shorter. So, Fred, you're getting shorter. You might have osteoporosis. Really? I feel fine. Most of the guys my age are getting shorter. Regular height measurement in older patients. When I was doing the data extraction for our OP risk tool, it amazed me how many patients did not have their height recorded in the record. And I had to send out an intramail to hey guys, you know, please, once a year, that's all I'm asking, once a year a height measurement. You measure the weight, measure the height once a year. What you indicated earlier, the kyphosis. I had a patient 3 weeks ago and I said, oh, look, it's a year since we last measured your height, let's measure it. She had a kyphosis. I said, look, I think you're a bit more kyphotic than last time. She dropped 4 centimetres. I didn't realise I was 4 centimetres shorter. Sent her off for a TL spine x-ray, multiple wedge compression fractures. Absolutely no pain. So she's coming back and she's going to start anti-resorptive therapy. So we find, we evaluate, we diagnose and manage, and then we keep ongoing management. You cannot cure osteoporosis. It's not like diabetes that you can push them into a metabolic remission or they have bariatric surgery and you've reversed the process until they regain the weight. This is a lifelong treatment. So finding the undiagnosed and those at risk. You know, this woman that I told you about who fell, it hurt. The vertebral fracture, this lady didn't feel. So that's not going to motivate her to come in and say, I think I've got osteoporosis. The fracture, you actually see the patient in a plaster of Paris or a fiberglass cast. They have the pain. They know something's happened. And we know something's happened. And it's just bring it to the front of your brains. Fracture equals osteoporosis till proven otherwise. How do you find them in a busy practice if they feel fine? And I'm harping on about it. I keep comparing it back to diabetes because I think diabetes has got enough traction and enough respect. It's time to transfer some of it to osteoporosis. They can't feel the blood glucose. They can't feel the osteoporosis. They can't feel the bone density. We think about diabetes. We've got to think about osteoporosis. So we need to think about risk factors. It's not just getting older. You know, we're getting older. We're going to be an hour and a half older by the time I finish this talk. Does that mean that just by getting older we've got osteoporosis? No. We can't stop aging. We're going to get older. We're going to enter our 70s. We're going to be at risk of osteoporosis. We can't prevent it. And I argued once, well, we need to start when people are 20 and start really focusing them on resistance activity and calcium intake and muscles to prevent osteoporosis, because that's the only way you're going to prevent it. You tell a 20-year-old you have to work at doing this exercise for the next 40 years to prevent osteoporosis when you're in your 60s. And they say, I'm not going to be around when I'm 30. What are you talking about? Right? Because they have got no concept of something beyond the next 10 years. Risk factors for osteoporosis is the way to approach it and stratify patients' risk. When you think diabetes and coronary artery disease, you think about family history, you think about smoking, you think about physical activity, you think about whether or not they're carrying too much central adiposity, you think about whether they're on steroids that pushes their sugars up. We think about all those things and an event they may have happened. We don't do that with osteoporosis, but we need to. So let's go through the red flags. Personal. Have they had a fracture since the age of 50? Red flag. Never ignore a fracture. Though I don't think they're as common as Osteoporosis Australia believes, we should start thinking about it and not ignoring it. Family history of osteoporosis, just like a family history of premature heart disease. Low body mass index, where they're too lean, and now we're actually seeing osteoporosis in our obese patients. There's now a new link. Menopause before the age of 45. Lifestyle. The lactose intolerant people who do not have an adequate dairy intake. Those who drink more than 10 alcoholic drinks a week. Inactive. Those who are having falls. The smokers. The comorbidities that exist because people will have more than just one condition. That's why they're patients with multiple disorders. But the big one is the chronic liver and kidney disease. As people hit their mid-50s and by the time they're in the 65, we're seeing an increased prevalence of CKD. There is a decline in the glomerular filtration rate, which increases the risk of cardiovascular disease and osteoporosis. And then medications, antidepressants, and the women who are on aromatase inhibitors because of their breast cancer prematurely. So they're more at risk of osteoporosis. So any woman who has breast cancer needs to have a bone density at the start before they do their aromatase, so we know at baseline. And it turns out that Prolia or denosumab has now got data that is so protective of bones whilst women are on aromatase inhibitors. So action point 5, become aware of the risk factors for osteoporosis. Think as you do for diabetes. And do the searches on patients for those risk factors and find them. And use this. There is a specific PenCap tool that we'll talk about at the end for osteoporosis. All right, okay. This is the lady that fell in the shower. She hypertensive, hyperlipidemic, depression, cares for her 85-year-old mother, premature menopause at the age of, and it's at 35, and she's been on HRT ongoing since. Bone density in 2013 showed a T-score of -1.2, so she's got osteopenia. Does she have osteoporosis? She slipped in the shower, hurt her back and her left wrist. She was taken to the emergency department by her husband, revealed no fracture of the lumbar spine, but a left Colles fracture, left radius fracture, and it was immobilised. I get a letter from the specialist, and he mentioned nothing about osteoporosis. I ring her up and I say, look, did the doctor talk to you about osteoporosis? No. When are you coming to see me? I'm bringing mum in on Thursday. I said, fine, we'll have a talk on Thursday. Does she have osteoporosis? Why possibly? Okay. Definition of osteoporosis. Any fracture from a standing height in the upper, above the knees, right, is a fragility fracture. And the next question is, would you have expected to fracture if you were younger? Would you expect to have a Colles fracture slipping in the bathroom if you're 25 instead of 55? Probably not. So by definition, even though she's got a near normal bone density, she has osteoporosis. She needs anti-resorptive treatment. All right? Okay. So, Susan, one of our mail-out ladies, she attended. No history of fractures. She goes to the gym. She's a non-smoker, non-drinker. Her mother had osteoporosis diagnosed at the age of 70. She's now 81 years old, her mother, and has fractured a lumbar spine. Her father has also got osteoporosis at the age of 86. He fractured his knife and he's got dementia. She came in because we sent her a letter and said, hey, listen, let's do a risk analysis for osteoporosis. She wants to discuss the menopause and her flushes while she's here. Could she have osteoporosis? Yes, she could. What's the probability? How many risk factors is she carrying for osteoporosis? That's the only one, family history. All right? So yes, she could. Does she qualify for a rebated bone density? No. So she pays the $60 and she has a bone density. If the risk factors are cumulative, how many red flags does she have? One. Just her family history. But that's enough. And, other information. Has she ever fractured? She answers no. How do you find these sorts of patients? You can't, because none of the PenCat extractions extracts family history. So we can't use family history as a screening, as a tool to search. So we have to be intuitive here and basically start recording it in an area that maybe the tool can extract it. Yes.
She develops something that's not picked up. She may say, hey, by the way, I remember you said something
Yeah.
that my heart started to affect the bone.
Yeah. Yes, and making education, making them aware of proton pump inhibitors and antidepressants and anything that will interfere with the bone density. All right, tools. All right. Now, this is the OSD risk tool. Now, imagine that how many of you use the Oz Diabetes risk tool for help? We all use it. It's a great engagement tool and it helps people understand if I change this, my risk goes down. Well, imagine that we were able to create a tool like this for osteoporosis, where patients can actually assess themselves for risk for osteoporosis or poor bone health. Let's call it poor bone health. And that's what, hopefully over the next month or so, our data will be analysed and we'll actually have an OP risk tool available to be tested and validated in the community. So technology is the way to go with this. Use technology and use the tools that we've got so we can find and manage people with osteoporosis. So actions for Monday. Find your at-risk patients. Do we link it to the pap smear? Bit difficult now because that's going 5 years instead of 2 years. Sorry? Yeah, well, let's call it the cervical cancer screening. Let's change, cervical cancer screening. What about men with a PSA? Again, men do not respond to recalls. Looking at chronic kidney disease patients, the path labs will gladly print out for you a list. You don't have to actually do anything other than ring the path lab and say, look, can you send us a list of all our patients who've got an EGFR less than 60? And suddenly you've got a list. Automatically having chronic kidney disease, guess what? It's a rebatable BMD. And polypharmacy. Find those who have fractured and slipped through the business model I've shared with you, and systems in place to ask about fracture. When they're there, ask them, have you ever had a fracture after the age of 50? Ask your at-risk patients, if you had this is the fragility fracture. If you had a similar fall when you were younger, would you have expected it to result in a broken bone? If the answer is no, it's a fragility fracture. And have you noticed any height loss? 2 simple tests to actually make you think, could this be osteoporosis? And eyewear, dizziness, osteoarthritis, anything that alters a person's ability to stop themselves falling or alters their ability to mobilise is increasing their risk of sarco-osteopenia. The more arthritic patients get, the less exercise they do. The less exercise they do, the more deconditioned they get. The more deconditioned they get, the weaker the muscles get. So the higher the falls risk and fracture risk. Now, this reframe is a tool that's currently available. Have you heard of it? Have you used it? Okay, you've heard about it here. Has anyone been in... Okay, you don't count.
I think he said we're the first practice in South Australia.
Okay, all right. What was your experience like?
It's in the process still. We've had the nurse coming out and screening the patient. Doctors were a bit slow to take it on board. You know, they're worried about drug company behind it, sort of thing. But they seem to be on board now.
General practice paranoia is alive and well. Okay. I think probably we need to put some Zyprexa in the water bottles of doctors to reduce our paranoia. Someone has to fund it, right? The government won't fund it. GPs want pharmaceutical companies to pay for their car parking when they go to a meeting. So I can tell you GPs aren't going to fund research and programs like this. So they shouldn't be paranoid when a pharmaceutical company says we're funding it, but we're independent of it. So we're just in the background. Thank you very much for accepting us. So it's crazy. But it's now, interesting. I've never gone through the Reframe program. Why do you think that is? No, hypomania. It's the opposite. We'd actually done it by the time it became available, right? Because we'd already put the systems in place. And when they came and did it, they found 8 patients that we missed. And I was devastated, right? Belinda, do you want to come forward? I was devastated. How the heck did we miss those 8 patients, right? It was really, if you want. I don't know. That's really what surprised us. And I had to go back and look at the systems and say, well, if we've got 500 odd patients, how do we miss these 8? And it made us revisit so that we didn't miss any more patients. But I've never gone through it, but I've used the resources. I've used some of the download tools that are available because they're useful tools. So I'm going to let Belinda share with you the journey, right? What happens from the minute you say, yeah, let's do it, to you get the output at the other end. It's all yours.
So I'll just introduce myself first of all. So my name's Belinda Robinson. I'm one of the nurse educators that work with the Reframe program. So we have nurse educators throughout Australia, and basically it's our job to work with GPs and practice nurses to help you through this process. So as Dr Michaelides said, a lot of money and time and research has gone into formulating a program that is systematic and basically supports you through that process. So we can come into your clinics and help you put in place screening tools, and the biggest aim of the program is basically to improve patient outcomes. So what we want to do is find these patients before they fracture to improve their outcomes. So the biggest part of our role is to come in and have a look at your systems and see which patients may have been missed for screening. So we work with the PenCat tool as well as various different types of medical software, so Best Practice, Medical Director, anything else that you've got as well, to go in and do searches and try and find those patients that might have been missed for screening. So we do look at 2 main groups of patients. We look at the over 70s who haven't previously been assessed for bone health, so they haven't had a bone mineral density scan. And then we look at the over 50s who have had a fragility fracture since the age of 50. We do find that group of patients are very hard to find, and a lot of it does rely on the coding But I suppose because we've been working in this area and doing this for over 12 months now, we've got some tips and tricks that we can share with your practices, and we can problem solve to try to work out the best way to find these patients. So from there, it's basically step-by-step guidance in that those patients, we can help you to do an active recall of those patients to bring them into the practice to get their referrals for their bone mineral density scan, and then they come back in for their results. And it's basically from there, we provide education to your staff about best practice around management for osteoporosis, and obviously the doctors, if they deem it's appropriate, they put them onto treatment. We don't advocate for any particular type of treatment. That's not our role as nurses. We leave that up to the doctors to determine what treatment they go on. We do provide resources of patient education. So most of you I've seen in the trade hall in the last few days. So you would have seen our booklets that we have that basically go through the self-management of osteoporosis. So it talks about calcium and vitamin D, talks about exercise programs, lifestyle risk factors and the like. And also we have a lot of other resources on our website, like a care plan that you can download into your medical software, and you can utilise that with the care plan that you currently use, or you might adopt the care plan in its entirety if that's what you need. So there is a lot of support and help available. And as I said, we are throughout Australia, so depending on where you are, we can put you in touch with the nurse educator that's working in your area. These clips are actually from our website, and our website is available for any health practitioners. So if you have an APNA number, so if you're a nurse or a doctor, you can register and you get free access to all of our resources. So you can see there's some videos as well, some extra education on bone biology, falls risk assessment tools, and all sorts of other things that you might find useful. Just another slide there that shows what the website looks like and the various different resources that are available. There's a really good slide deck on there. You can sit down with your patient and educate them quite comprehensively on osteoporosis and give them all of that information that they need to increase their understanding of what they're dealing with. And another thing that we have as well as part of the program is an accredited clinical audit. So what we do find is that sometimes there's so many competing priorities in general practice that sometimes the GPs need a little bit of a carrot to get started. And this, as well as being a research project, is also an opportunity for them to get something extra out of it. So the clinical audit requires the GP to see 15 patients who haven't had a bone mineral density scan in the last 5 years. So either the over 70s or you're over 50s with a previous fragility fracture. And they go through, they consent those patients, and then they just complete a survey form on each of those patients, just showing exactly what they did. So whether or not they were put on treatment, put on a care plan, so on, what their results were. Following that, they get 40 Category 1 CPD points, which goes towards their RSEGP points. Is that what it's called? Sorry. Yeah. That they need?
It's our CME, Continuing Medical Education, for our vocational registration.
Thank you. I've forgotten what the term was. Yeah. So what I've found in the practices I work with, because of those competing priorities, if I want to get a practice GP, I suppose, thinking a bit differently and having osteoporosis in the front of their mind as a patient walks in, this is a good way to start, because it can be overwhelming. I've got other practices I've worked with when we've done the searches, we've found 450 patients that have been missed for screening, so that's really overwhelming. And it's our job, I guess, to work with you and problem solve and find a manageable way of doing it. So whether we look at smaller groups of patients to begin with, or those ones that are perhaps more at risk to begin with.
Okay, so if we look at the summary of the action points, poor bone health is common. I've shown you that the prevalence of osteoporosis is higher than the prevalence of diabetes. We need to be proactive, both for the patient to maintain their quality of life and be responsible for how the health dollar is utilised. If we're proactive at helping identify patients, preventing fractures, which prevents morbidity and mortality, we're going to save money. Fractures change lives, Structured care is the best way to do this. The episodic care, which is Band-Aid medicine, which is we rely upon the patient to turn up. They can't, I've got a bit of a head cold. Yep, let's just treat this episode. Oh, by the way, maybe we'll think about osteoporosis. Oh, forget about it, too busy today. We missed the boat. Becoming aware of risk factors so that we can find patients. Patients are not going to turn up and disclose and say, I've got osteoporosis. They won't do that until a fracture occurs. But if we look at risk factors, we're going to be able to identify patients early. And technology has the structure that we need to find, diagnose, assess and manage osteoporosis. Now, two final statements. We can't change what we don't know. So we can't manage a patient with osteoporosis if we do not know they exist. And we can't manage what we don't measure. If we're not even thinking osteoporosis and looking at bone mineral densitometries and looking at the history, we're not going to be able to help manage that condition in that patient because we won't know it exists. So the take-home messages are put diabetes to the back of your mind for a month, bring osteoporosis forward, enjoy the ride because it really is worth it. Yeah, you put the systems are migratory. You can move them from one chronic disease to another. And think about the ABCD model where you've got a checklist. And as you go through it, you're actually doing optimal, good osteoporosis care. Okay. Any questions?